Good morning, everybody. I would like to welcome you to our weekly resident lecture, which is given today by Dominique Behrer. Dominique is a 6-year postgrad in our department, and she will move forward soon to her research fellowship, and she will give an interesting talk on the Rolling Stones. Please.
Good morning from my side, and thank you very much, Professor Petrovsky, for the introduction. Today's topic is the Rolling Stones and their complications. Well, I'm not quite familiar with what problems the Rolling Stones encountered during their life as a rock band, but they can appear from benign to wild horses or truly malignant. And to draw a connection to the Rolling Stones in our body, they can benign resting gallstones in the gallbladder, asymptomatic, or to say it in a Rolling Stones song, they become wild horses, move on to a cystic duct, and become real beasts of burden when moving a little bit further and obstructing the main pancreatic duct. Our talk today is structured in an anatomic route and an extra anatomic route. And I invite you today to join me on a gallstones journey through the anatomic route first, and then we move along to the extra anatomic route. In the content, we will focus on the surgical treatment of asymptomatic and symptomatic gallstones, the acute cholecystitis, Meritzi syndrome, choledocholitis, biliary pancreatitis, and we will talk about the bilioenteric fistula, gallstone ileus, and Bouveret syndrome. 10 to 15% of the US populations have gallstones, and only 10 to 25% of them become symptomatic. And in 1 year in the United States, 800,000 cholecystectomy are performed. So the European Association for the Study of the Liver have published guidelines for the prevention, diagnosis, and treatment of gallstones. And when we have symptomatic and asymptomatic gallstones, the question is, when should we perform the cholecystectomy? And when you have gallstones, as marked in red, which have become symptomatic, it's a preferred option to perform a cholecystectomy. When you have an asymptomatic gallstone patient that was found by accident on an emergency ultrasound, for example, it's not recommended to perform a routine treatment with cholecystectomy. But then there's still the question, when should you perform the cholecystectomy? And in their opinion, and also in our clinic's opinion, we should perform the cholecystectomy as early as possible for patients with uncomplicated biliary colic, because the operation is much easier to perform at that stage. But what happens now if the stone is proceeding and impacting the cystic duct? An acute cholecystitis is developing due to fluid secretion intraluminal and prostaglandin I2 and E2 secretion, which increase the redness and the inflammation, the general inflammation of the gallbladder. The gallbladder gets distended, the gallbladder wall gets edematous, and due to bradykinin and histamine, which are also secreted, the peripheral nerval endings are sensibilized and the patient starts to feel pain. When seeing that in an operation room, you get first a hyperemic mucosa, which can be patchy. As you can see, this can proceed up to a necrotic gallbladder wall on the bottom right-hand corner. If this gets worse due to a microcircularity problem, and bacterial overgrowth can cause a secondary bacterial infection of the gallbladder wall, and it becomes a gangrenous cholecystitis. An empyema, usually subhepatic, can appear, or it can become even an emphysematous cholecystitis. As you can see on the computer tomography on the right side, here you have, where the arrow is, you have air in the gallbladder, and you have an aerobili here in the liver. They're usually associated with a Clostridium infection. And does anyone know which Clostridium type this kind of emphysematous cholecystitis can cause?
Is it the Clostridium perfringens?
Yes, exactly. Thank you. So in this case, we shouldn't wait, and we should operate the patient immediately. There's no role for delayed surgery or postponing it to the next day. But what do we have on a study when to perform this cholecystectomy when you have an acute cholecystitis, not in a gangrenous emphysematous cholecystitis? So this is a study by GUT. It's a multi-center randomized trial. They enrolled 618 patients, and 304 received an immediate cholecystectomy in less than 24 hours, and 340 patients became a delayed laparoscopic cholecystectomy. First, antibiotic treatment, and after 7 days to 45 days, the operation. And the result of this study was that they got significant differences in a morbidity score, in hospital stay, and hospital costs. The conversion rate was the same. And when we look at the meta-analysis, comparing the different randomized trials on an early versus delayed laparoscopic cholecystectomy, it is also in the favor of early laparoscopic cholecystectomy. Then Hula published in 2016 a new study where it's said that an early laparoscopic cholecystectomy for acute cholecystitis can perform safely even 72 hours after the beginning of the symptoms, and is still associated with less overall morbidity, shorter hospital stay, duration of antibiotic treatment, as well as reduced cost compared with delayed cholecystectomy. In the summary, we can say the ESL guidelines still promote that an early laparoscopic cholecystectomy, preferably within these 72 hours, should be performed early and should be performed by a surgeon with adequate expertise and for patients with acute cholecystitis. Now moving on to the next topic of the Merizzi syndrome. Does anybody know what the Merizzi syndrome is?
It's the obstruction of the hepatic duct through a stone in the cystic duct.
Exactly. So the Merizzi syndrome is characterized exactly by an obstruction of the proximal bile duct due to an extrinsic compression by either an impaction of the stone, as you said, in the gallbladder neck, or it can be local inflammatory processes. Also, this is a rare syndrome. In developed countries, it appears in 0.7 to 1.4% of the cases. The preoperative diagnosis has to be very carefully managed, and it is essential in order to avoid vascular injuries and misdiagnosed malignancies. So we have different types of the Merizzi syndrome. It's the severity from type 1 to type 4. It's just a question of how much it's eroding the gallbladder wall and how much it's protruding into the common bile duct. So it's rare, but we have to remember and think about it. It may range from asymptomatic to obstructive jaundice, and the diagnosis is often very difficult. So Kulkarni has tried to, in their retrospective chart view of 4,900 patients that underwent cholecystectomy in a single institution during 6 years, to observe which Merizzi syndrome types have developed cancer, which Merizzi syndromes had to be laparoscopic or could be laparoscopically operated, and which had to be converted to an open operation. And they found of all these patients, 60 patients that had a Merizzi syndrome. Type 1 were 16 patients, and type 2 Merizzi syndrome, so they had already a little erosion to the gallbladder wall, were attempted in 9 cases laparoscopically, and all of them had to be converted to an open operation. So as a summary, or to draw a conclusion, if you know that you have a Merizzi syndrome, it's better to think of an open access initially. If the stone, though, is moving more further to the common bile duct, we had a cholecystolithiasis, and this happens in 5 to 20% of the patients. It's mostly secondary, and primary is only in rare cases. And you can see on the imaging a dilated common bile duct. So how should we treat a patient with cholecystolithiasis? And the American Association for Gastrointestinal Endoscopy categorized risk factor in order to figure out whether the patient has a high risk for having a cholecystolithiasis. And here you can see a table seeing if you have a very strong risk factor, you have a strong or moderate risk factor, and what the likelihood is to have a cholecystolithiasis. Having these facts, then you can choose your management option. So if you have a high risk, according to this table before, you should perform a preoperative ERCP. If you have an intermediate risk, you can think of a laparoscopic intraoperative cholangiography and make a laparoscopic common bile duct exploration or perform a postoperative ERCP. The other option is to perform an endosonographic ultrasound or MRCP, and in a positive case, you can still perform the preoperative ERCP. With a low risk, obviously, we can perform a laparoscopic cholecystectomy without cholangiography. And now we move on to the real beast of burden from the gallbladder stones, the biliary pancreatitis. It's the most common cause of an acute pancreatitis. This can be lethal for the patient. The biliary pancreatitis accounts for 50% of all the pancreatitis, and as we said, it can be very mild to very severe and necrotic. So when should we operate on a patient who has acute biliary pancreatitis and we know we have to take out the gallbladder? The EASL says clearly that the cholecystectomy should be performed during the SAY hospital admission, and that is the preferred option for mild and acute biliary pancreatitis. So I have a case from our hospital. It's a 60-year-old patient, and in the beginning of July, he was referred to our hospital with symptomatic cholecystolithiasis. It was first indicated in 2014, and the surgery was indicated. We were discussing with him the operation, but he had already plans to go on his holidays, and so we postponed the planned operation. But then, in the end of July, he was referred back to us from Pristina, Kosovo, with acute necrotizing pancreatitis. And as you can see on the computer tomography, the pancreas is dilated, is edematous, has necrotic part. But we chose a step-up approach with an initial interventional drain placement, and there was an instant emptying of 1.5 liter of cloudy liquid. In the second step, by recurrent vomiting and recurrent infection and failure to advance diet, we use a video-assisted retroperitoneoscopic debridement. And then 2 days later, we had to make an open approach and with a necrosectomy, splenectomy, and cholecystectomy. And unfortunately, in this case, from a very mild symptomatic gallbladder disease, this became fatal for the patient. So what happens when the gallbladder stone doesn't go its normal way, but chooses to take a shortcut to the duodenum? This is called the bilioenteric fistula. Bilioenteric fistula can cause different problems. They can cause gallstone ileus, or they can cause gastric outlet obstruction. And the different ways the gallbladder can cause different fistula formation to the duodenum, to the colon, or even to the stomach. And as you can see, it's the most common that it's a cholecystoduodenal fistula due to the anatomic proximity. Facts on these gallstone ileus, it's in 1 to 3% of the small bowel obstructions, And 0.3 to 0.5% of patients with gallstone disease will suffer from a gallstone ileus, and the highest incidence is seen in elderly female patients. Fortunately, stones below 2 centimeters can pass the rectum. There's an increased risk for impactations when the stone is over 2 centimeters. So, looking at the distribution of the stones in gallstone ileus, in 73% the stones are seen in the terminal ileum. And please, any of the students or assistant doctors or residents, tell me why do they occur in the terminal ileum?
Due to the valve of Bauhin?
Yes, exactly. So, hand on heart, who has heard from the Bouveret syndrome? Does anybody know? So good. I will explain what it is, and we will by looking at one case. It's a 65-year-old patient. He came to the emergency room with chief complaints of eating intolerance, nausea and vomiting, and weight loss. And a CT, computer tomography, was performed. And as you can see, the stomach here, something is not okay. Probably a stone here that is obstructing, and the stomach is dilated and has lots of liquid. So it's a gastric outlet obstruction. And this is exactly the problem in Bouveret syndrome. The gallstone is obstructing a proximal duodenum so that the stomach cannot empty itself anymore. Consecutively, you have this gastric outlet obstruction. In this case, in this Bouveret syndrome, the stone was taken out and the patient was good again. So, moving on to the take-home messages for the surgical treatments. In a symptomatic cholecystolithiasis, a laparoscopic cholecystectomy should be performed. Acute cholecystitis, an early cholecystectomy is proposed. Mirici syndrome, we should think of it, and we should initially choose the open approach if possible. Cholecystolithiasis is primary domain of ERCP at first. And in biliary pancreatitis, the cholecystectomy should be performed during the hospitalization. And if you have a biliary fistula or gallstone ileus, you can still choose between a 1 versus 2 stage procedure. So if you have an ileus and a strongly inflamed situs in the fistula region, you can choose first to operate on the ileus, and in a second stage operate the fistula. So think of it, gallstone disease may have many phases of clinical presentation. They could range from mild to life-threatening conditions, and it should not be underestimated. And here I put the EASL guidelines again. It has about 670 references, and this is what we used in this presentation as a recommendation for the surgical treatment. And thank you very much for listening.
Thank you very much. Excellent presentation, very important, because that's a common disease, and misdiagnosis, mistreatment may just result in death of the patient. So that's a very important topic. I also like your Rolling Stone story, because if we understand the pathogenesis, the pathway, then we understand the symptoms, and very often logically we have the right treatments. The most common cause of death of patient is mixing cholangitis, choledocolitis with cholecystitis. When you would treat the cholangitis when the stone is in the common bile duct with a cholecystectomy, and patient will die from sepsis after, because you solve. There's a number of gray zones, I think, here that all with the guideline can be discussed between ERCP or surgery. I think there's a few. Just a few comments that I took note. Importantly, the most frequent gallstone is asymptomatic. You present that, and I saw in the guideline, which escaped to me, they put low evidence that we should not do surgery, or the low recommendation. The evidence we can always discuss. It's really pretty unclear definition, but they show a low recommendation. That I think is not correct. I think here the asymptomatic gallstone should not be operated. Otherwise, you operate 30% of the women more than 65 of the age, and you take the gallstone. There are exceptions, patients with gallbladder cancer in different area in Chile, where really you need to take the gallstone very early because it evolves in cancer. But I think it's very clear, and I think insurance may also not pay if you operate just because you see gallstones. The problem is asymptomatic gallstone in symptomatic patient, meaning that they have problems but unrelated to the stone, and you take out the stone and they still have the problem after. That's a more difficult situation. As the comment, I think it's clear the acute cholecystitis should be operated right away if you can. The evidence is very strong. You delay, it's not clear how long you should delay, and there's this study from Lausanne that you showed that we should operate anytime, regardless of the time, as soon as we can. This is also a little bit unclear. This is our policy here in some way. I mean, case by case, we have to see also the risk of surgery in the patients, etc. So sometimes it's better to give antibiotic because most of all of these cases will respond to antibiotics. So you can delay, it's probably more expensive. So it's a case by case, but we also have a bit this philosophy here. You cover very well many topics. You could not, with the gallbladder cancer, we should not also forget that gallbladder cancer is most of the time related to gallstones, not always, but most of the time, I don't have the exact figure, is also to symptomatic gallstones. So they have cholecystitis, recurrent cholecystitis that can go to cancer or can go, but the number of these cases, in fact, have gallstones, which have been almost no symptoms and develop cancer. It's not a reason to take out all the stones in the population, but it can happen. So, I mean, it was very good presentation. Thank you. If there is questions or comments.
I got one question. There's always this discussion whether an acute cholecystitis should be operated right away in the middle of the night, or whether it's safer to wait until the next day. Are there any data to compare the outcome of night versus daylight surgery of acute cholecystitis?
Yeah. So the recommendation said it should be done if you do it in an emergency setting of an experienced surgeon. So that's the limitation. I think if you have just a cholecystitis and no severe cholecystitis, this is no role for do it at night surgery, like any other surgeries which we did last time, because what can happen if you have perhaps not so much experienced resident is alone, and we had this also in our department, that you could have severe injury to the vessels or bile ducts, so do it safe. So the story is different. If you have emphysematosis, cholecystitis, or even perforated cholecystitis, then you have to go. But for a laparoscopic approach, I would not do it in the night.
For some special part of the population, like diabetic patients or pediatric patients with asymptomatic cholelithiasis, what is the management? For example, some guidelines state that sickle cell disease should be operated in pediatric patients, and some used to say that diabetic patients should have an early cholecystectomy due to the rate of, or the amount, or the severity of infection they can develop. So how are the guidelines nowadays here?
So the PED guidelines, I cannot tell you because I'm not a PED surgeon, with especially sickle cell anemia, so we should ask them. But if you have risk factors, as you said, we should go for early cholecystectomy. This would eliminate also any delay in these high-risk populations. But again, if you have cholecystitis, you come to the emergency room in the night, and you have diabetes, there's no role to do it immediately right away. So, but also don't, if you have a spot, don't postpone this, and
Thank you very much for your talk. I have a very specific question about gallstone ileus from a bilioenteric fistula. Would you just relieve the ileus and not touch the fistula, or would you go for fistula repair and cholecystectomy? How's the management in this case?
It depends from patient to patient, and then how severe the inflammation process also in the the fistula is, because sometimes it's a chronic inflammation that you have this fistula, and it can be acute inflamed as well. And then you have in the distant part of the intestine, you have the problem of the ileus. So first you will want to relieve the patient from the ileus symptomatic or this ileus problem, and then you first operate on that. And then a second stage, when the patient is better and maybe stable, because maybe he's unstable before, then you choose to operate the bilioenteric fistula.
I think you answered right. I mean, I think the problem is the ileus, so you need to take that out, do an enterotomy, take it out without delay for this. Then it's unclear, and then usually that elderly patients, very poor conditions, etc. So very often the best is to let in peace, just do that and nothing else. The question is when. You should never attend in middle of the night to fix the fistula. You end up in a disaster. The question is after whether you go, so there is some recommendation just to do an ultrasound to see if there is residual stones. If there is another big stones, patient is in relatively good condition, that's justified to go back and to do it. It's not a benign surgery. It's clearly an HPB surgery. If you have fistula, you have risk of problems. If you have no stones in an elderly patient or very small stones with a fistula, then the best to keep the patient in peace and not do anything in the logical way. So it's really case by case situation. It's pretty rare situation. We don't see many gallstone ileus. We have an elderly population. We see more mesenteric ischemia, very frequent, but gallstone ileus, I don't know how many we see in the department here. We have seen a few. It's a single-digit number in a year, at least, that come to us with this condition.
Perhaps one adjunct to this question is also you have to look at the type of fistula. So if you have a colodochoduodenal fistula, which is much more complicated, because also to repair, comparison if you have only a small colonic fistula, which you might easier to repair in the same procedure. So this has to be also go into the equation. Okay.
Thank you very much. My question is regarding a moderate suspicion of common bile duct stones in the acutely symptomatic patients. Is the MRCP or the endoscopic ultrasound the preferred way to go?
Well, there are some institutions, even in this country, like in Basel, they do in every gallstone disease an MRI. Even if there's no suspicion at all, even if there's no suspicion. So we don't practice this. If you have a low suspicion, sometimes, in my opinion, is to wait a little bit and to see how the blood tests develop. So usually they present with high transaminases, elevated bilirubin, and if this is transitory within the first 24 hours, that means you can observe a decrease. Then you know you probably have a stone passage, and then you probably don't need an ERCP and can schedule the patient for cholecystectomy. But if the liver function tests are still increasing after 24 hours and the symptoms increasing, I think you should go to ERCP. It's a clear domain for this. Yeah.
And indication for MRI in such a patient?
Good question. If you have enough time, you can do it, but usually if you have an ultrasound, you have a localized stone in the common bile duct and you see even still rising enzymes, I would not delay with an MRI, I will go for ERCP. We have also our gastroenterologist here who could also make a comment.
The advantage of the imaging by endosonography, which is usually that what we do if it's not clearly a stone visible already in the transcutaneous ultrasound, is that you can then proceed immediately to therapy. So the MRCP imaging is nice maybe for academic reasons, but doesn't really help you in the sense that you can then proceed to whatever treatment you choose.
Well, I mean, make a comment. It depends of the institution, and here you treat patient also in function what you have in a hospital. If you have some center they cannot do ERCPs or they are not very good record, and you may manage the patient differently that if you have a center with expert gastroenterologists. So, in that situation, you may go for surgery up front, treat it, and then postoperatively, if it's needed, then you can still do the ERCP and clean that up. If that's not the case, then you're a bit stuck because you may end up to the choledochotomy and other more complicated operations. So I think here you have really to adjust to what is around you in terms of the surgery or what you may do.
A special situation might be the situation after gastric bypass. And there, if you have like a symptomatic gallstone disease after bypass, an MRCP might be a good option to get some preoperative clearance, what might be needed intraoperatively or even postoperatively.
Should we take the gallbladder when you do this, you have asymptomatic cholesterol stone in this gallbladder, which I may imagine is not so rare. Should we take out here the gallbladder if there is no symptom when you do a bariatric procedure?
No, our policy is not to take it out if there is no symptoms from the gallstone disease. If they have symptoms like any other patient with or without gastric bypass, we have the same approach. If it's symptomatic, we can do it. Depending a little bit on the course of the gastric bypass operation, if that turns out to be very complicated and technically difficult, we wait a few months and take the gallbladder out later and take the risk of more symptoms.
Okay, good. Thank you.